it shouldn't be meaning that they can swallow. So I capture a few things. I think that's what I can remember. Thank you.
Okay. Okay. Yes, who else?
Say, let me add up more. And then they have to sleep on a firm mattress, not a soft mattress.
Okay.
And then they should always be in a supine position, not prone position.
Okay. Who else?
Yes, and then they shouldn't sleep. They should sleep in the same room with the parents, but not the same bed.
Who else? Lindy, are you there?
Yes, sir.
I mean, what do you know or what have you learned so far?
Okay, so
Pediatrics.
I've learned that when a baby is born, it goes through stages.
Okay.
So I learned that there were three people that classified them under various stages, and then under the stages, whatever happens. So we look at the Erickson theory, and then we also look at Sigmund Freud theory, and then Piaget. So Piaget was talking about the cognitive aspect of a child. And then Sigmund Freud was also talking about the psychosexual aspect of it. And then the Piaget look at the psychosocial. So I learned that with the psychosocial, it deals with their mind and then their environment, whatever goes around them, how their mind is able to perceive it and how they interpret it. And then with the psychosexual, that one deals with their senses and then their sexuality. Then with the psychocognitive, that one also deals with whatever they have in their mindset, what goes on in their mind. So there, I also learned that we have a infancy. The infancy stage start from 0 to 1 year, and then at that stage, they go through trust and then mistrust. And then with the toddler stage, that one is from 1 year to 3 years, where they go through, they also have autonomy versus shame and then doubt. And
Okay.
then we have the preschool. The preschool is also from 3 years to 6 years. They also have initiative versus guilt. And then from there, they move to another stage. That is the school age stage. That one is from 6 years to 12 years, where they also go through the industry versus inferiority stage. And then the last one that we look at was at the adolescents. We pick it from
Okay.
12 years to 18 years, where they also
Okay.
have uh, identity versus role confusion. So you took us through the various steps and what actually goes into it. Thank you.
Perfect. Perfect submission. Wow, Lindy, you are so sharp. I never knew you were so good like this. God bless you. Yes, Victor. Victor, what do you know? Tell me. What have you so far grabbed with pediatrics?
It's a good deal. I just joined. Please, what was it? I just joined right now.
Okay, so the question is, we've come far with pediatrics. So what have you so far grasped with pediatrics? All the things we've learned. What have you so far taking notice of.
Yes, sir. The 3 to 6 years, the Ericsson initiative is good. Yes, 3 to 6 years, and then we learn that Paget also, that's where they have the pre-operational, and then Sigmund Freud will have the phallic, and then yes, they are cooperative in this stage.
Okay.
Yes, sir. And then they can run easily. They can ride tricycle, and then they can climb a well. That is the gross motor. And then the fine motor, they can feed themselves, and then they can dress up with minimal help.
Okay.
Yes, sir. From the 3 to
Perfect.
6. Yes, sir.
Perfect.
Thank you.
Right. So who else? Let me check another person. Curtis, please, Curtis, call me today. I have an appointment for you. I have a deal for you. If you can hear my voice. Yes, Curtis. Are you there? Okay. Joanna. Hello, Joan. Is Joanna there? Okay. Joanna is not there. Lee. It's a Lee's iPhone. I'm saying a name here by name. Lee's iPhone. Yes, pediatrics, pediatrics. What can you say? Man. Yes. Christian. Yes, Tommy. Your hand is up.
So I want to try.
Okay, try.
Okay, so what I learned was that we have I learned about the developmental stages, and then we learned that um from 0 to 1 is the infant stage, and then we said that at that stage there is something called trust versus mistrust. That's 0 to 1 years. Like um mostly when they are crying, they need somebody to comfort them. So when you ignore them, they don't trust you anymore. Or when you don't come closer to them, they feel ignorant.
Okay.
Then we also learn something about the infants. The infant that is 3 to 6. The
Okay.
3 to 6. And then the 3 to 6 too, we said that that one is the initiative versus shame. So at that stage, the autonomy versus shame. So at that stage, they want to do things by themselves. They try to do things by themselves. When you intervene, they become
Sorry,
annoyed.
Tom, sorry for intervening. Tom, is 1 to 3, which is the shame, autonomy versus shame and doubt. I think so.
Okay.
One
Yes.
to three.
Shame
Yeah.
and doubt.
So yeah, so 1 to 3 is the autonomy versus shame. So at that
And doubt.
stage, they become autocratic. They want to do things by themselves. So immediately you shout on them, they become very shameful, and then they do not want to continue to do whatever thing that they were doing initially. And then we move to the preschool. The preschool is the 3 to 6 years. At this stage, that's called the initiative. The initiative versus inferiority. So at
Okay.
this stage too, they try to do things by themselves. They try
Okay.
to do things by themselves anyway. And then also we have the school age. That's the 6 to 12. So at this age, they become very dependent. Like they try to do things by themselves. They are they understand whatever thing that is in the society. They understand good and bad. So
Okay.
at this stage, they decide for themselves. Nobody decide for themselves. So that's basically what I learned about the developmental stages.
Let's go to the systems. We started with the respiratory system. What can you say about the respiratory anatomy or the anatomical structures when you take a pediatrics respiratory system or airways? What can you say? Start from their mouth, their tongue, their epiglottis, and the airways, and the nose, nostrils, whatever. Yes, what can you say? Who else? Mhm. Mhm. You had a long weekend, so you see, you have forgotten. Yes, I know you people know.
Hello, sir.
Yes,
Okay, so let me say something more about the epiglottitis.
start from
So
the
with
anatomy.
the anatomy,
Mhm.
so asking what?
The anatomical structures of child or pediatric.
Hmm.
Shoot. Um, Mafodwo, are you new here? What do you say about the tongue of a little child?
So please let me try.
Try.
I remember you said that for children they have a big tongue, uh unlike we the
Big.
adults.
Good.
Yeah,
They
and
have
because of
big
that,
tongue.
they are prone to obstructions. It can obstruct their airway.
Yes. Then what can you say about their epiglottis?
So I'll say it's very small. So when they get
Yes.
choked, when they get there, you said something about flapping.
Floppy.
Yeah, floppy. Yeah.
Floppy this. Floppy. Yes. Their epiglottis is floppy. Okay. So what can you say about this? Lumpy and soft. So when they get epiglottitis and you are not careful, you can burst it and they will aspirate. What can you say about their airways? Yes,
So the vessels there are very narrow.
the vessels. Vessels supply. These are blood vessels supplying the airway. This is the airway. What can you say about this child's airway?
So I can remember you said the area was narrow.
Mm.
As
It's inside here. It's narrow. The listing, I mean, when they try putting something and mistakenly enters into the airway, it can easily occlude here, block this side. or whichever side. Okay. And oxygen cannot go, carbon dioxide will not come, and they will struggle. Okay. Yes. So these are the things we did. Okay. We also spoke about pediatric fluid and electrolytes. Then we spoke about the dehydrations. Okay. So we did the mild, the moderate, and the severe. We've done it already. We also spoke about the oral ORTs, so rehydrations, commercial, getting into a drugstore to get, especially this Pedialyte. Okay. Avoid water only, juice or soda. Okay. You always, when they have dehydration, give them something with electrolyte in it. Okay. Perfect. Then the IV for severe ones and moderate, if you want to go by that. Then we started with the pediatrics. So I told you that we are entering into the system by system analysis. So that is what you should know. Okay. So we started here. We saw their airways. Those of you who have forgotten, the airway of a pediatric is narrow, one. So the least thing obstruction occurs. Their tongue is large. This is the qualifier. Okay. Their epiglottis is floppy. And they consume a lot of oxygen because they need to grow and develop, especially the growth. Their cells are just multiplying. So oxygen needs to go to their cells for metabolism and ATP production. So they consume a lot of, children consume a lot of oxygen than we adults. And their diaphragm, this one nobody mentioned it, is the primary breathing muscle. Okay. Yes, they have lungs. Okay. The lungs has what? Ribs. And even between the ribs, we have muscles, the intercostal muscles. Okay. They have the sternocleidomastoid, they have the clavicle, whatever. But their primary breathing muscle is the diaphragm, the one sitting below here. So that is what you should know. Okay. So when the child gets respiratory distress, there is a lot of pressure on the diaphragm to help the child. If the diaphragm collapses and you are not careful, you are in trouble. So respiratory distress is a priority over all other systems when it comes to pediatrics. Okay. Perfect. When they're in their mother's womb, their priority is the heart rate. Take note. Okay, we talked about stridor and wheezing. I told you never to forget about these two brothers. Yes. So as the airway is blocking, you ask yourself which part of the airway is blocked and which part are we hearing the air passing by the blocked area. So example, if this is the airway and this side is blocked like this, the air the child breathes in and the air they breathe out, it will try and force itself within this small space or small space. Okay, depending on the obstruction. So, or on the other side, a child has asthma. Okay, children cannot get COPD. Forget. Asthmatic attack, inner lining or the mucous membrane are getting swollen by this. So this is air obstruction. So the air will try and force itself. Okay. That one to produce some like air, you force air through a narrow space. Okay, kind of a reason. So you do your stethoscope analysis or assessment and know, are you dealing with the upper respiratory system or the lower respiratory tract? Okay, if it is upper, on the A, B, C, D to Z algorithm, you will meet S before W. So why should you struggle to memorize this? Don't memorize it. Okay. Stridor is always at the top of the upper airway, and wheezing is lower airway. That's it. It's one thing. It is one thing. These two brothers, they are it's the same thing. It's like a river flowing from the north of whichever country you are to the south. On the north, it has a name. On the south, it has a name. When it gets to another town here, the town people will give the same river the same name, as a certain name, by the same water body, the same river. So that is what is happening here. Okay, right. Let's look at some of the respiratory disorders. I've done some additions. I've added some little notes for you to know. The first one we are going to look at is what? Croup. Croup is one of the common childhood illnesses that causes swelling around the voice box and windpipe. Okay. Yes. What is the function of the voice box? Who knows? The larynx. The voice box. Who knows?
It's for phonation.
They didn't hear you.
Yes, I said it's for phonation.
Phonation, yes. I'm using my voice box to help me produce sound. Phonation. Okay. What the trachea? The function of the trachea. Yes. To pick.
Yeah, it directs air into the what do you call it? The alveoli.
Directs air into the bronchi or the bronchus. Okay. Yes. So this is the carina or whatever. So this is the trachea is a muscle with semi-circular rings over here, like this. Okay. So, like my brother said, Dave said, it directs. Okay. But Dave, next time use the word it conducts. It's a conductor. It conducts air. So if this one does
Okay,
not
sir.
squeeze, if the trachea does not squeeze, air will never breathe air into your nose. Let it go to your the pharynx, the larynx. Let it enter into the trachea. If the trachea does not squeeze, the muscles here, they don't crash. Air will never move down. So when the muscles become weak and they don't crash to push the air in and out, what will happen? The patient will be diagnosed with a condition called tracheomalacia. Have you heard of it before? Trachea muscle weakness, call it tracheomycia. It's an emergency. Somebody has gotten what? Nerve injury. Some nerve supplying the trachea is gone. Okay. Trachea will not work. The muscles will not contract. So at this moment, we need to puncture the trachea. We need to puncture the trachea, and we insert a device, an airway device, into the trachea so that we can deliver oxygen to the lungs. So we have cricothyroidotomy, the neck puncture. Me, I don't have Adam's apple, but those people who have it, okay. So the thyroid gland and the cricoid cartilage, in between the cricoid and the thyroid gland, there is a small muscle here. Okay. In emergency situations, palpate this and palpate that and locate this muscle, puncture it with an IV cannula or whatever, a syringe or whatever, deliver oxygen to the patient. Okay. But when you do this, that is not the end. You have to transport the patient to a higher facility. If the patient is on message, patient should go to the maybe ER or ICU or whatever. Then they will do what? Tracheostomy, emergency tracheostomy for the person. Okay. So these are the things you should know. Okay. Just by the way, this trachea, this larynx, and the upper part of the bronch. Yes, Dave.
Hello, sir.
You want to hold your question, then I finish. You can write it down so that you don't forget.
I wanted to find out the term for that process.
Hypothyroidectomy, cricoid cartilage. So cricoid and thyroid. Omi or otomy or what omi is like opening, creating an opening. So between the cricoid cartilage and the thyroid cartilage or gland, whatever, there is a muscle. The muscle is like this. So puncture it. Let me show you a picture of it. We call it the cricothyroid membrane. So cricothyroid membrane. Anatomy. So the men, if you get a patient who is a man with a protruded Adam's apple, you are lucky. Me, I don't have that structure. So okay, so you see this one. The thyroid cartilage, the cricoid cartilage. So in between them, there are some men with these structures that are protruded outside. So it will make even the job simple. Put a pillow under the back of their neck. Remove the pillow from the head. The patient's head should not be on a pillow in emergency situation. It should be at the back of the neck. Let it protrude these structures out. Then you puncture it. Where is your biggest, or what is your biggest IV cannula? Gauge 16 or 14 or whatever. Okay. This ash and all these. Puncture here. So once you puncture, don't go far. Otherwise, you puncture the back of the trachea. It's like this. So just give a little puncture like this. Boom. When the air starts coming out, gushing out, that's it. Connect your oxygen device. Some people can use syringe. But remember, you can't deliver oxygen to someone without creating a small hole where carbon dioxide will pass through. Otherwise, they'll build up carbon dioxide and cause brain trauma. So those of you who use syringe, sometimes they will use this surgical blade to cut a small space here on the syringe. Okay. And that is it. I mean, it is an emergency. Somebody is choking. You choke at the top here. Air is not going. Nothing is coming. You have this place here. Don't let the patient die. Do it quick. When you finish, call ambulance. If it is in the small towns, call ambulance. They will come for the patient. Okay. So you see how it is. It's lined. The cricoid cartilage is here. And the thyroid cartilage is there. That's just by the way. Let's continue. So the larynx and the bronchi, okay, they can be infected by bacterials, okay, and cause an inflammation. So look at these two structures. So your cricoid, these ligaments are on there. So the cricoid cartilage, okay, and the thyroid. So the inner or these two structures can be infected by upper airway infections. Okay, your baby, are you doing proper oral care for them? Are they eating too much sweet that is building up microorganisms in their mouth? All this winter weather will change. Summer is coming, a lot of dust. Okay, airway infections all over. Children, when it happens like that, their cricoid membrane or the thyroid structures and the upper part of the bronchi or the bronchi will get inflamed. When it gets inflamed, air will not go down. So you'll be experiencing a wheeze-like breathing. But what happens? Their way, they try to cough out. Okay, they try to cough out, and they are coughing out. They cough out like a dog which is barking. A dog which is barking. So you experience the hoarseness, the inspiratory stridors, which is worsening at night. I did a short video on why children cry when they sleep at night. When you sleep, there is accumulation a lot of what? Mucous membranes. That will even worsen respiration and breathing. Okay. So you need to use all these sprays, cold mist, and all those stuffs, okay? The zametazones to relax all the swelling. Epinephrine in severe cases. You keep the child calm. Crying worsens the situation. Okay. Yes. It typically affects children 6 months to 3 years old, and it's usually caused by viruses such as influenza, parainfluenza, all those. Okay. Yes. So all these ones you should know. Never forget to the croupy cough. Croupy cough. Now, epiglottitis. So when it happens like this, because it's a viral, mostly influenza, we give them, if it is very severe, we give them a certain medication. We call it oseltamivir. Vitamin V. And I've told you, those of you who joined the class so many months ago, I told you that antivirals, you don't have to chew it. Just ask yourself, what is my name? Add VIR, virus to it. That is it. So I have David Ver, whatever Ver, Ayariga Ver, okay, VIR, antiviral medication, VIR is always added to it, majority of them. So you don't have to chew it. Okay. So they will give you a list of medications, antibacterials, antivirals. Then they will bring you a croup cough, a croup condition. Once you hear barking cough in children, that is the cardinal sign. Asthmatic can get hoarseness, they can get stridors or wheezing. These two brothers, 1 and 2, that is it. They can bring you a whole page NGN question. But these two brothers, they will give you the year of the child and these two backing course. That's it. You are done. You should know where your answer is. Now let's go to epiglottitis. Epiglottitis. We are still on the upper airways. Okay. So this is a medical emergency. I have told you that the epiglottis is floppy, already soft. Okay. So it's caused by inflammation and swelling of the epiglottis. That's the flap of tissue that covers the trachea during swallowing. Okay. So when it blocks, or when it swells, it can block the airway and children will struggle to breathe. That is it. Yes, aciclovir is there and all those stuff. Okay, sorry. Let me enlarge my screen. Some people cannot see it well. Please, is it better now? Let me know if it is better at your end.
Yeah, yes, sir.
Okay, ma'am. Thank you. Right. So I was saying that the epiglottis, this is the airway. It covers it. Okay. So let me ask you this question. The esophagus and the trachea, which one comes first? And which one is behind the other? This is the patient. This is the neck. These two brothers are lined together. This is the front of the patient. So you're looking at me now. So if I want to puncture you from outside here, anterior to posterior, which one will I meet first? Is it the trachea or the esophagus?
Sir, I
Yes,
think the
Joanna.
trachea. Oh,
The
sorry.
trachea. No, that's fine. Yes, the trachea. Do you know why? Why was this not changed? But this changed. Do you know why? Who can tell me? Yes, think about it. Yes. I just mentioned it.
So is it due to the position?
It's in front because in situations of air obstructions, that is the easy reach to save a life.
Yes. In situations of air obstruction, you can easily save a life with it. Secondly, this ring, the complete ring, of the trachea. When you press it, when you use your tongue to depress it, we call it what the cricoid pressure. You know this cricoid cartilage I showed you. This one. It is part. You see, it's part of the ring. So the cricoid pressure, when you press it, this bone cartilage, when you press it with your hand, it blocks. It blocks the esophagus. So when something is inside the patient's stomach, let's say pregnant woman, emergency, we need to intubate them. Somebody has eaten. And the person may be driving emergency state, we need to take them to theater, intubate, or do airway management. Somebody will just use the thumb, just use this thumb like you are watching, or either these two hands, fingers, use it to press. That's why you need to know your anatomical structures, where you can find which. Okay. Always the cricoid is under the trachea. Okay, so take note. So the cricoid, you press it. When you press, it will block the esophagus. So like this. Let me go back to our slide. This is my stomach. I have eaten fufu here with plenty soup. Okay. This is my esophagus. Is here. And this is my hot trachea. This is my cricoid cartilage. If I use my thumb to press this crack, it will block here. So nothing will climb up to find its way into the airway. Okay. We keep it there, so we put an ET tube inside and inflate the case before I remove my hands. So that is what you should know. Okay. So
please,
that is why it was arranged that way. Yes, Genevieve. Let's shoot.
Can you please repeat that again? I didn't get it well.
So this is your stomach. Genevieve has eaten jollof plus egusi soup. Okay. Her stomach is full. But Genevieve has forgotten that she has what? An esophagus. Okay. And on in front of the esophagus is your trachea. Okay. The trachea will bifurcate into the lungs like this. As Genevieve, there is an emergency, and Genevieve, we need to secure the airway because Genevieve has what? Has eaten jollof. This jollof, it hasn't digested, it's still in the stomach. So jollof can regurgitate, aspirate. Remember, the patient, when Genevieve ate the jollof, she was standing like this. But now Genevieve is unconscious. So her position has changed like this. With this big stomach and the fufu and whatever is climbing up. One, Genevieve's position is not favoring her safety. Okay. Ooh, because she is weak, her muscles will also be weak and relaxed. So the epiglottis, which we are relying on to close the airway, is also weak. So we can't trust the epiglottis that we will leave Genevieve in this position. So what do? Let's bring Genevieve's position up like this. So Genevieve is now 45 degrees like this. Okay. That is, we are fighting against gravity. Another one, we have the cricoid cartilage here. Let somebody hot press the cricoid cartilage. This cartilage, it will go and block hot because it is a full ring. If you take the trachea is full of half rings. But the only ring that is full is this one. It is like a wedding ring. It goes around the trachea. So when I press the front, the back will close the esophagus. So Genevieve's food can be in her stomach when the food tries to climb up. Because this place is closed, it will go back. If I don't press here and I give my anesthetic medications, the food will climb, get here. It will shock you that the epiglottis will allow the food to enter the airway. You are expecting Genevieve to vomit. She won't vomit. Even if she vomits, some will still pass here. Okay, so that is the physiology. Okay.
Thank you, sir.
Genevieve is yes, Tommy. Keep your answers so that we move fast.
All right.
Okay. Right. So let's continue. So that's epiglottitis. When your epiglottis, why is it that we don't want your epiglottis to become inflamed? Because the epiglottis cover the airways. Where are the women? You cook soup. This is the bowl or the cooking pot. You have a lid. That is the epiglottis covering the airway. Now, epiglottis is inflamed. Okay. It will cause a lot of salivation in the mouth. Patient will be having difficulty swallowing. Okay, because of the pain. Sometimes they assume the tripod position so that they can even breathe and feel comfortable. We have muffled voice. Take sound and mix sound with water in a bottle. Okay. Yes, and blow vibrations. Let the sound vibrate through the water. You get a mixture of sound and water plus the vibrations. We call it muffled. Yes. Do not try to do any throat exam, because when the epiglottis becomes inflamed, the least touch it will rupture. So this one has become inflamed. Then the inflammation is coming from a bacteria or a virus or whatever, with pus accumulation in it. If you try and do throat or airway examination and something touches this epiglottis and it ruptures, all the pus is going where? Inside the lungs. You are going to cause what? Pneumonia. You are going to infect the airway and cause pneumonia. Okay? So don't try. You give your antibiotics. That's it. And sometimes you secure the airway. Okay. Let's go down. Now we have entered into the bronchioles. The inflammation of the bronchioles is what? Bronchiolitis. This is a viral infection that causes inflammation, swelling, mucus buildup in the smaller airways of the lungs. It is the most common. So this, you remember, the bronchioles, okay? The IOLE, the bronchioles. The more you go down, then the bronchiole becomes smaller, then, okay? So if I do stethoscopy here and I hear air moving through an obstruction, where did I hear the air? Was it when the patient is breathing or when the patient was breathing out? Okay. So I would say if it is in, because this bronchioles, where is it? It's in the lower respiratory tract. I can't call this stridor. I'll call it what? Inspiration wheeze. And when it is coming out, I'll call it expiratory wheeze. Clinical assessment, you should know that airway, your rate, your volume, and your rhythm. You should never forget. Okay. So you do your supportive care, oxygen administration, suction. This is a viral infection. Don't try antibiotics. You are wasting. You are wasting. If there is no bacteria and you give antibiotics, the antibiotics are going to attack your immune system. So at the end of the day, you are causing what? Immunocompression or suppression. So take note. Don't give antibiotics. Don't go to the drugstore and buy antibiotics and drink if you have not done any culture and sensitivity to confirm that whatever you are going through is what? That is number one. Whatever you are going through is a bacterial infection. Secondly, if you haven't done any vital signs for to know your temperature, your heart rate, your blood pressure, and all those stuffs for the sepsis protocol to be triggered. If the sepsis protocol has not been triggered, don't try antibiotics. Because that antibiotics you are taking, when it goes into your system, it is going to fight your immune system and further depress it. Okay, perfect. So that is what you should know. Okay. So bronchiolitis, wheezing, crackles, retractions, poor feeding in these children. So all these ones, you see it. Okay. Next one, asthma, almighty asthma. I love asthma because if you know the physiology of asthma, you will know how to treat asthma. That is it. You treat asthma on the physiology. Okay. So asthma, you say we will not call this stridor because you now know why we call it a wheeze. Okay. We don't get asthma of the upper airways. We get asthma of the lower airways. Okay. The bronchial tree. The tree. Okay. So let's go. This is the bronchial tree. It has an inner lining. Inner lining. Emanuela has passed. We used to use her to. She will go and buy a house and buy carpets. So the inner lining is called the mucous membrane. The mucus or the mucosa. Okay. We have the muzzle layer. The muzzle layer here. Inside this mucous membrane, there is another sac here. It looks round like this. The name of this sac is called goblet cells or globlet, whatever. It contains the mucus. Okay. So when this place is dry, when the mucous membrane is dry, it will what? It will secrete a little so that the airway will be moist. Why do we want the airway to be moist? because the air around us, the atmospheric air, is very dry. There is no humidity or little humidity in it. So when you give somebody dry air and the airway becomes dry, what happens? When the air gets to this place that they need to exchange, the dryness will harden the mucous membrane. Yeah, it will not make it soft and moist. It will be dry. And when it's dry, oxygen cannot cross, carbon dioxide cannot come. That is why people with cystic fibrosis mostly get problems. Don't let your mucous membrane to be dry. Okay, now let me ask you a question. How do you know that your mucous membrane is dry? David, you are talking to Thomas. You cannot see Thomas's mucous membrane. So which part of Thomas will you look at and say, Tommy, go and drink water. Your mucous membrane is dry. Yes. The reverse, Tommy can answer.
The reverse, nobody can answer.
David can answer. Yes.
David, right? Yes.
Yes, Gloria. Gloria wants to help.
Gloria wants to help.
Boss, I think it's the lips and the tongue.
The lips is number one, and the tongue
is number
or the oral cavity. Okay, but the lips. When your lips are dry, it means your mucous membrane are drying up. So you need to moisturize, drink water. Don't go and use lip gloss. That is not water. Yes, you can protect the integrity of your lips by using the lip gloss to make it oily. But what about the mucous membrane inside you? It needs water. It needs hydration. Okay. Asthma. I'm not going to waste time. So, in asthma, they are hypersensitive to external factors. Like we call it the, how do we call it? The triggers. Okay. It can be pollen. It can be just normal spray. It can be dust. This mucous membrane, this mucosa, the problem with asthmatics is that this mucosa is super sensitive to all these factors. Yes. So once the mucous membranes get in contact with these triggering factors, they begin to swell. And when they are swelling, it means the goblet cells that is holding the mucus, the phlegms, also what begins to become big. And it will get to a time that it will rupture, it will burst. When it bursts, it releases a lot of thick mucus into the airway. Before, we didn't have thick mucus here and plenty mucus here. So this accumulation of this mucus, so this is number one. This is number two, accumulation of mucus. The patient cannot breathe. Air is not going in and out. So what happens? She will try to cough it out like an aspiration, a foreign body. So coughing it out. So you see asthmatics, okay. These muscles will run into spasms. It will run into spasms and cause all this chest tightness, accumulation of CO2. Okay. Yes. Getting air into the patient is not a problem. Getting CO2 out, okay, becomes a problem. So CO2 will be building up. And remember, CO2 behaves like an acid. That is why we say it is an acid. CO2 behaves like an acid. Because the proverb says, if it looks like a duck, it quacks like a duck, it flies like a duck, and it behaves like a duck, then it is a duck. So if CO2 acts like an acid, then it is an acid. So acidosis will be building here. A lot of CO2 will accumulate here. Patient will try to breathe the CO2 out, but the CO2 will force itself to pass through the swelling here, these obstructions here, and it will create a sound, that forceful expiration. Remember, we are dealing with the bronchioles, the bronchial tree. So the bronchial tree is not part of the upper respiratory tract. It is part of the lower respiratory tract. So this forceful air passing through, we can't call it stridor. So don't go and write any nurse's note and write stridor for asthmatic. It is a big mistake. Okay. You write what? Expiratory wheeze. Okay. So if I want to treat asthmatic, I need to relax this muscle. The inner lining, I need to what? Relax it, the mucus. And the plenty accumulation of or secretion of mucus into the airways too. I need to quash it. Okay. So I'll give a certain medication. We call it the bronchodilators. Yes. Those medications go to your airway and what? Open up the airway. I have opened up your airway. Does that mean the mucus that are swollen? Let me clean the board. Now, the bronchodilators, these guys, they have opened up the airway like this. So the airway has become like this. That airway we saw. But remember, this mucous membrane is still swollen. It's still swollen. Okay. So there are some asthmatics when you open the airway. Now, yes, CO2 can come out. Oxygen can come in. No stress. Okay. But how do I relax this swelling? I need to give anti-inflammatory medication or steroids. Okay. So the clomethazine, the zamethasone, all this zone to relax it. That's it. You give your oxygen, put patient on monitor them, and you are gone. So that is it. Okay. Go to pneumonia. Everybody says pneumonia. Somebody said, I went to sleep in home and I got pneumonia. I travel abroad in the winter and I got pneumonia. Pneumonia. Okay. Pneumonia is an infection. Take note. It's an infection of the lungs. Take note too. That causes inflammation of the alveoli. That leads to fluid and mass accumulation and impaired gas exchange. That is it. So what brought about this infection? What brought about? Is it that a certain food aspirated and it went to the airway and it was sitting there, generated what? Bacteria, and started causing issues? Because you can't say you are exposed to pneumonia factors today and tomorrow you are diagnosed pneumonia. No. Whatever bacteria that got here or whatever substance that got here has incubation period, sometimes 2 weeks incubation period. So those of you who work on message, you see the adult people, the elderly, when they are on the ward, when they are on the ward, you realize that if you live with an old man in the house, you realize that once a while they will cough. Once a while they will cough. Okay. Then some 2-3 days, persistent cough, then it stops. Those signs are showing the incubation that something is going on in the lungs. So for it to get to a stage that the patient cannot breathe, the oxygen is dropping, or the temperature has gone up, the patient has passed through the incubation period. Now it is an active diagnosis. Okay. So coughing is the first sign. There is a foreign body that came here. The alveoli were telling you that, hey, this is not where this guy is supposed to be. It's a foreign body. Cough it out. And you coughed. But you did not give attention to it. And the cough was once a while persistent. Short time, you not hear it again. Then it comes. Okay. Yes. So when it becomes an active infection and it start producing what fluid. When it start producing fluid, so it's like a pool here. So when air passes through this water, you hear that sign. That is crackles. This is not inspiratory wheeze or respiratory wheeze. This is crackles because of what? There is an accumulation. Accumulation, where is it? Of fluid or pus. Yeah. So that is what you should know. Okay. And let's go to, so you do your antibiotics, you do your chest x-rays. Okay. And I mean, you make sure you quash the bacteria, you go on your way. Cystic fibrosis. I have a short note for you here. So cystic fibrosis, I was telling you that the cells that your body had when your mother gave birth to you, all those cells have died and new cells have come. Just that when they were dying, a new cell was there to replace it. That is why you did not die. That is why your organs did not fail. Yes. So our body is in such a way that new cells will die and new ones will come. New cell, we call it disformation. New cells die and old cells will die, new cells will come, old cells will die, new cells will come, old cells will die, New cells will come. Okay. Some people will inherit some genetic cells that will come and affect the mucous membranes. So you remember what happened with asthmatic guys, where they were having thick and dry mucus. Okay. These guys too also what? Inherit new genes that will cause what? The mucous membrane, instead of it to produce mucus that is watery, it will now be thick, at a certain point dry. Okay. So let's go to our body. Where can you find mucus? In the airway. In the GIT too, there is a mucus. You eat food. Without the mucus, the food cannot go down. And without the mucus, when the food gets to the small intestine, it can't cross. It can't cross to join the portal circulation to the liver. It will be stuck here. So this patient will be having absorption problems. Let's go to the airway. Okay, it's mucus in so many places, in men, in the ureterus, and all those. All those stuffs. Okay, yeah. Airway, you've breathed in air. The oxygen has gotten here. It needs to cross and go to the bloodstream. The mucus here is dry. Oxygen cannot. So there is air trapping here. So don't joke with your mucus. Yes. So the mucus, this is the note if you want to learn. A thick mucus, chronic cough, recurrent infections. That's the dangerous aspect, because the mucus, they are not supposed to stay in the airways. They are not supposed to be stagnant. Stagnant water. It will cause infection. It will generate microorganisms. Okay. Inside the pancreas, there are a lot of mucus. Pancreatic juice has what? Been released. We need mucus for food products to cross, to be digested. Mucus is dry. Pancreatic enzymes cannot get into the pancreatic duct to go into what? The small intestine and help with digestion. Okay, so the nurse must help with airway clearance. Then you also eat what? High caloric and high protein diets. That is what you do. Okay, because this is a life-shortening inherited disorder. And it's don't pray you get this. As your new cells are coming, don't pray the new cells will come with this type of disorders, because it is life-shortening. It shortens your life. Inherited disorder causes thick, sticky mucus to build up in the lungs, the pancreas, the intestines, and some major organs. It is caused by mutations in this type of gene. We call it the CFTR gene. So that is what you should know. Okay. Sometimes in autosomal recessive pattern. Okay. Yeah. So these are the things you should know. Foreign body has been aspirated. We now know the physiology. There's going to be cough, choking, unilateral wheeze. Toddlers at higher risk. 1 to 3. So age appropriate choking maneuvers. You know all these maneuvers. Okay. Nowadays, we even have devices that will suck it out. So when you get money, you buy some and put it at home. Okay. So giving children oxygen, nasal cannula for mild hypoxia, simple face masks, non-rebreather in severe hot distress. Yes, we don't want you to rebreathe the carbon dioxide. So we call it non-rebreather. Then high flow nasal cannula. Please don't give high flow without a humidifier. You are going to dry up the mucus quick. So somebody will open nasal cannula to 14, 12 flow rate. Okay, 14, 16, 12. Yes. That patient who has been brought to the emergency unit, the patient cannot breathe. You think you have opened the oxygen cylinder, whatever, flow meter. You've opened it wide. The oxygen is flowing. The oxygen you are giving to the patient, it is, if you don't connect that oxygen to a humidifier, a water chamber, that the oxygen will pass through first before it gets to the patient. You are going to, yes, you're giving oxygen, saturation is up. But remember, you are drying up the mucous membrane. So you are causing what? You are this one, this is not genetic mutation. You are causing cystic fibrosis. And the fault is coming from the health worker. Because the health worker has refused to pass this oxygen through a humidifier with water here. Okay. So you see, I mean, it's good you come and learn so that you do the best thing. Suctioning techniques. Always suction patients. Okay, let me ask you, I'll not answer. When do we suction patient? Is it breathing in or breathing out? Yes. Yes.
Breathing out.
Why?
Breathing out.
You should explain your answer. Why?
That's when carbon dioxide is
Yes.
expelled. So it helps. It helps in in managing the distress.
Okay. Another point. Top it up. You are right, by top it out. It helps to manage. You said breathing out. Ooh, perfect. Boom. Okay. This is my airway. And this suction technique applies to all patients. Please, not only pediatrics. Okay. Whether patient is having ET tube, whether patient is having tracheostomy, whatever fluid is accumulating in the airway, you need to suck it out. Whether fluid is in all these babies who are doing Apgar scoring, all these babies are sucking. Yes, you want to do airway management, suctioning. You suction out. So if you forgot, we always suction out. We don't suction and push the mucus back. We suction out. So breathing out or expiration. That is the time you suction patient. Okay. Why? Because respiration is a cycle. And the cycle says breathe in, breathe out, and a pause. Okay. Breathe in, breathe out, and a pause. So when they are breathing in, this is the time they are supplying the body with oxygen. This is not the phase that you are going to suction the patient. You suction that oxygen you are sending to the body. You suction it out. And there will not be enough oxygen here to cross to the bloodstream. So never try suctioning with breathing in. Okay. But when the patient, let me tell you that, let me show you the beautiful physiology here. Now breathing in is gone. Oxygen is gone. Carbon dioxide has come here. It is now time for breathing out. So when this carbon dioxide, when the patient starts breathing out, you start suctioning. Okay. So it will give you time. Look at the face. Oh. You have all this breathing out phase to suction the patient, and you have all this pause time. So you have enough time to suction the patient. And when the patient starts breathing in again, you stop, and the patient will take the oxygen in. So you have good space to suction patients. Don't start from the breathing in. Because when you start from the breathing in and you suction this oxygen that is supposed to go into the body, you suction it out. Remember, after the breathing in, now you have starved the body with oxygen. Oxygen, the patient is starving with oxygen because you have hijacked the oxygen that was supposed to go to the patient. Okay. Now the patient has moved from breathing in to breathing out. That is when you stop. When you stop, the carbon dioxide will come out. But at that same time, the body will be starving for oxygen. And this is an emergency situation. Okay. And after breathing out, another pause will come. And you what? You will still be starving the patient. So you are going to starve the patient from the beginning of the cycle till the end, until we get another breathing in. And you know what some people will be doing because they don't know this physiology. The next breathing in will start. They will still suction the patient again. So within the time, you realize that your oxygen saturation is dropping down. You are causing starvation in the body. So you prevent what? Hypoxia. You always limit the time. Then pre-oxygenate if needed to build what? Functional residual capacity. That's it. Okay. That is very important. Then nasal for suctioning, you do ball syringe for infants. Then you nasal or oropharyngeal suctioning before breastfeeding for all those stuffs. Okay. So this brings us to the end of respiratory issues for kids. Let's go to
Hello, sir.
cardiovascular. Yes, ma'am.
Sir, please, during suctioning, which part do we suction first? Is it the mouth or the nose?
Oh. Children breathe through their mouth a lot because they have small nostrils.
Okay.
You understand?
Yes, please.
Yes. They breathe through their mouth a lot than their nostrils, especially babies. Small nasal cannula, nasal space. Okay. Yes. So it's a good question you asked. I love it. This is their oral cavity. Okay. This is their nasal cavity. Always the nasal cavity is sitting on top of the oral. I've never seen a patient that, but this nasal cavity is small, unlike we adults. So children breathe through their mouth a lot, a lot, a lot. A lot. That's why when you are doing pediatric CPR, baby has been born, the patient is not breathing. You do that face mask, then
Okay.
more the mouth and nose. Okay.
Back.
Yes, you do it. Okay. Yes. Because majority of the air you are pushing in go through the mouth. Remember, the nasal cavity and the oral cavity meet at where? The pharynx. Here's the pharynx. We call it the pharynx. So we have the oropharynx and the laryngopharynx. Okay. And the nasopharynx. So below the pharynx is the larynx, the voice box, where the sound is. Okay. Then it goes down to the other way. So the 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 nasal part of the pharynx. The pharynx is a big structure like this, but some comes here like the river. The part that you can see when you look through your nose and you see the back of the nose here. That back that you see is the upper part of the pharynx. We call it the nasopharynx. When you look through your mouth, okay, you see the pharynx here because it's a journey. It travels from down here to up here. So this part of the mouth is called the oropharynx. And the part that connects to the larynx, the voice box below here, is called the laryngo part of the pharynx or laryngopharynx. You understand? And the voice box is sitting here, waiting for you to produce sound. So those of you who join choir practice, they will tell you that sing through your stomach, but you do a lot of voice training. You are training what? Your larynx. Okay, that's just by the way, guys. Let's go. All right. I mean, when I'm teaching, I don't want to go fast because I want people to understand. Okay.
Sir,
Yes. Yes.
so does it mean the mouth should be last? The mouth should be sucking last.
It depends on your airway assessment. If I listen to your chest and I don't hear any wheezes, okay, why will you even suction wheezing? You suction wheezing when you hear that, oh, the air that was passing through that you heard as wheezing, there is some crackles attached to it.
Okay.
Crackles, okay. Crackles means air is passing through water. So which water is our mucus is accumulated there that I need to suction it out. If you do your airway assessment, okay, upper lower, upper middle lower, okay, for the right side, and it's all the airways are clear. What are you going to do down below there? Okay, to do anything down below. You focus on the upper airways. Are there stridors? What? If they are stridors, I mean, or they are crackles. Suction. So let's go to the cardiovascular. Cardiovascular. So cardiovascular, we are going to look at the congenital heart disease. Okay, that's very key. You can't dodge it. If they want to test you on cardiovascular for pediatrics, congenital, very important. Okay, Let me go down here. This is the heart of every human being. The heart is divided into two, the right side and the left side. Okay. But remember, we have the lungs here, and we have another lung here. And the heart is always in the middle of these two brothers. Okay. So the inferior and the superior vena cava will come like this. And empty whatever they have here. Remember, when they were coming, they were bringing deoxygenated blood and a blood with less oxygen. So deoxin or CO2 more. They brought it here. The blood gets here, and unfortunately, there is a hole here, or there is a hole here. Or when it gets to, let's say, this side, and it's supposed to go through here, the pulmonary arteries, any blood vessel that leaves the heart is called an artery. Okay. So if your name is connected to the heart and your duty is to take blood away from the heart, your name is called Lydia Artery. But I'm seeing your name. Okay. So deoxygenated blood is coming. When they got here, they are coming from the right side and they are going to the left side. For some reason, the blood drop here. I'm creating a story for you because we will go deep for you to know why some children have heart disease, but they are still alive. And some children, they have heart disease, but if you don't take care, they will die within some few seconds after birth. Okay. Why are some alive? And why are some still? Some we have to do an emergency operation for them to survive. Even after the emergency, nowadays that we have a lot of advancement. This is what I'm saying. So the blood that was supposed to go through the lungs first and get oxygen and come back before it goes to the body. For some reason, when the blood came to the right side, they managed to find their way to this chamber. Did they pass through here and jump down here? Or did they pass through here and jump straight here? Or is it that when it was going, there was a shunting? What happened? Okay. So in this case, we call it what? The right to left heart or congenital disease or disorder. Okay. The right to left. So if the blood gets here, remember, the blood did not go to the lungs. It did not go and collect oxygen. And it has found its way into the left ventricle. So it means the left ventricle's duty is to always see the left ventricle doesn't care. If you like, go and fetch water in the gutter and come and put it in the left ventricle, it will pump it to the system. He has only one assignment. His assignment is that any fluid or whatever it receives, it pumps it into the system. When the left ventricle receives clot, it will pump it out. When it receives any rubber, anything, when you put any poison in your blood, that is why when people get snake bites, poisonous snake, they easily die if you don't take care. Because once this snake poison gets to the left ventricle, the rest of the body is saturated with poison. The left ventricle doesn't care unless you have ventricular failure, that it will hold some of the water or the fluid. Other than that, it goes. It doesn't care whatever you brought. It's not a postmaster that will sort out. This one will go to this house, this one will go to here. No, he pump it out. Okay. So when children have these conditions, we will mention the condition. When they have right to left conditions, what happens? The least thing, they are cyanotic. And the cyanosis, you are going to see it is central cyanosis or sometimes generalized cyanosis. Yes. The least thing, they are dying. So that is what you should know. Okay. The same heart is divided into two. The blood is coming. Blood got here. Let me divide this one. Blood got here. It went to the heart. Okay. It went to the lungs. When it was coming back and it got here, the left atrium, because the left side of the heart has a lot of pressure. There is a lot of pressure there because the left side of the heart pumps blood. Okay. It will sometimes, if there is a small hole here, the pressure will push some of the blood here. But remember, the blood that is coming from here is full of oxygen. So even if it goes here, comes back here, goes back, enter here again, and go here before going here. The only difference is that the journey has become long, but it is still oxygenated blood circulating around. So when this oxygenated blood finally pumped by the left ventricle into the system, the patient can live. These children will be living sometimes 18 years, 15 years before they will see that this child, when he was born, he had a hole in heart. He has so and so. He had this. Because as you age and your cardiac power goes down, then these conditions will start coming up. You can't hide it. It's like pregnancy. It will pop out. Okay. So all these conditions that falls under blood moving from the left side of the heart to the right side of the heart, we call them what? Acyanotic. So it can be that you and I, we have a heart disease from childhood, but our problem is what? Left to right heart problems. So we will be walking, we will be talking, we will be playing, eating what we eat until one day the heart begins to mess up. That doctors will know that, oh, let us go and take scan. Oh, let us go and do echo. Oh, let's take you to the cath lab. Oh, so you were having what? A heart problem from childhood. And it is now that we are seeing. You are now 12 years, 15 years, 20 years, so many years, yes. So this is the big fact. I have made it simple for you. So let's go down and look at the conditions that falls under them. Okay. So left to right or right to left, we call them cyanotic. Their nickname is called cyanotic. So anytime you hear cardiac doctors saying this is a cyanotic heart disease, you should know that the blood is moving from the right side here to the left side. That's it. Okay. If we say acyanotic, because no doctor will write this diagnosis in any patient's folder. They will write cyanotic or acyanotic. If they want to be more specific, they will write the proper diagnosis there. But if they want to make general, It will go this way. Okay. So it is a heart defect, okay, when deoxygenated blood from the right side of the heart bypasses the lungs and enters the systemic circulation. This results in bluish discoloration of the skin and mucous membranes due to decreased oxygen levels in the blood. Okay, so the blood will move from the body toward the right side of the heart to the left side, okay, then the body again. Okay, so let's look at what are the conditions that comes with what right to left. We have so many heart diseases in this world. We have so many heart diseases for children. Okay, number one, the first heart disease is called tetralogy of Fallot, or some will say Fallot. It's a noun. Anyhow you want to mention it, that one, it won't buy you food. It won't buy you water. Anyhow you want to pronounce it, that's it. Okay. For a child to be diagnosed as you are having tetralogy of Fallot, it is a heart disease. When they take a scan or they do echo or they examine the heart, they will see that this child, this is your heart. The heart plus the blood vessels plus the chamber. We have found 4 diseases all together occurring at the same time within this child. Okay. All diseases. If we look at your heart as a whole, the muscles of the heart, the septum. So we have the septum. We have the ventriculoseptal, whatever, this one. We have the pulmonary arteries. We have the aorta, whatever, all the blood vessels, the muscles, because when they are doing echo, they do all those stuffs, okay, or cath lab or whatever, or scans. They will see 4. So you get to a child that has 4 medical conditions happening in the heart at the same time. So they will dig that child, tetralogy of Fallot. What happens? The first medical condition is what? Ventriculoseptal defect. So this child, when I draw the heart of the child, I have a septum that divides the child's heart into right and left. Then I have this one to here. But you see this septum, like the linear arbor. The down part here, you see a hole, big hole here. Was there supposed to be a hole? Okay, then the doctors will mark it, number 1. Number 2, the pulmonary, ideally, when blood gets here, it should get here. Then it will join the pulmonary arteries to the lungs. This pulmonary artery has become smaller, stenosed. Okay. Or sometimes the valves inside the artery have become stenosed. When we say stenosed, something has become fixed and it has become squeezed and nothing can pass through it. So you realize that all the blood, if I sent 1,000 mils of blood to the right ventricle, instead of going through this place, it will pass through this hole. Where is the next destination? Left ventricle. Ventricle says, whatever I receive, straight to the body. I don't have time for you. I'm not a sorting master. Okay. So this child, so now we have 2 conditions of the child. Okay. Ideally, the blood that got here, some were supposed to even flow back. Okay. But because of the pressure in the left side of the heart, okay, we realize that, you see the aorta, the aorta, anytime you see, like you and I, we don't have any heart problems. So this is how let me divide this into two here. Always, always, this is your pulmonary artery. It is like this. And the aorta, it is always on top like this. We don't have a problem, or you and I, we don't have any medical condition in the heart. So always the pulmonary artery is below. Look at the level. This one is at the top here, and this one is here. So always the pulmonary arteries are below the aorta. But this child has this problem. So the same heart like this. This child is having a pulmonary artery here, and the aorta rather is down like this. So we call it overriding. The aorta has overloaded the pulmonary artery, and it has, like Jacob and Esau, who the junior brother was very smart, and he came. I mean, he took the blessings away. The same thing happens here. Okay, so already this child, this pulmonary artery is closed or almost closed. There is a big hole here. This is also another hole in heart. It's a big hole here, but this hole is not at the top here. It's at the bottom here. So we call it the ventricular septal defect here. So immediately the blood, deoxygenated blood, flows from here. Because of the pressure here, when the left ventricle pumps, it will push, because already the aorta is ready to receive any blood here. It is dancing inside there. So it will pump, it will push all the blood to the system, or almost all the blood. So you see what we call overriding of the aorta. Okay. Then the last problem of the tetralogy of Fallot. Okay. The left ventricle, the ventricles are created in such a way that their duty is to pump blood out of the heart. And God, in his special wisdom, connected the pulmonary artery, the PA, to the right ventricle, and connected the aorta to the left ventricle. If something happens and the ventricles are not able to pump blood, the muscles begin to multiply. Like somebody who has gotten cancer cells, they multiply. The cells of the ventricles, they multiply. You will not see that much in the aorta, the atrium, but the ventricles, the least thing, if the right ventricle, if it is the duty of it to pump blood to the right pulmonary artery, and it cannot pump, you see that what the muscles at the right ventricle will begin to multiply. New cells will come and add to it. So today it is a little smaller, tomorrow a big smaller, a big larger, then it goes like this. So you realize that the ventricles have become big at the right side. Okay, it has become bigger at the right side compared to the left ventricle. So when that happens, we call it what? The right ventricular hypertrophy. The child that you gave birth to, and I pray nobody gives birth to this child. It was very stressful. you sleep in the ICU forever. Okay. Yes. So this child that was born is having all these 4 medical conditions happening at the same time. Can this child grow to 15 years, 20 years? No. Okay. It will demand a lot of medical attention and financial sacrifices. Okay. Or we do a heart transplant. You have that money. Family members will say, let's leave the baby to die. After all, you can give birth again. Okay. So you realize that all these physiologies and all these problems end up pushing blood to the side. And when, okay, so this child will be in the house, small thing, central cyanosis. So if this is the body of the patient, okay, and the head, they always get blue. Even when they cry, see, give them any activity that will stress the heart. That's it. They will turn blue. They will turn blue. You don't have to. This is a trick I've given you now. Because those of you who are going to do NCLEX and those licensing exams, when you see this condition, ask yourself, among these options, which one is giving the stress to the heart? Okay. Anything. Can this child run? In fact, it won't work. He will turn blue. When this baby is distressed, there is heat in the mother's room. The baby is crying, stress to the heart. Okay. Yes. Okay. So what now happens? You get what we call the death spells. The death spells. The nasal bed, the bed, the nail beds are not getting, and the fingers and they are not getting what? Enough oxygen. So they will assume a nature we call the clubbing. People with big nails and all this, we call it clubbing. Okay. At this moment, we need more blood back to the heart because there are a lot of what? Deoxygenated blood in the body. So what do we do? Are you going to turn the baby upside down? You are going to cause cerebral circulation overload. Okay. Will you turn the baby's head down and the body up, the legs up? No, plenty blood will flow to the brain. So what do? Let me rather take the leg, push it up, help with help push most of the blood back. It will create that force and push some blood to the lungs so that we get what? Oxygen into the body. Or we get some blood to collect oxygen from the lungs and back. So I will hold your legs. We call it the knee chest position. Will you lie the patient down and elevate the legs? Can this child allow you, a child under 1 year? Are they going to obey instructions and sleep in this position like an adult would do? It won't work. So knee chest position. Then you calm the baby down because when they cry, it puts pressure. See, when you cry, as I'm talking like this, my heart muscles, you see the way I'm sweating. My heart muscles are demanding for oxygen. Oxygen, yes. Because I am exercising. Talking is an exercising. Okay. So when this baby cries, their heart muscles are demanding for oxygen. But the blood too is not getting to the lungs. Where can we get the oxygen? The body will turn blue. Okay, it will turn blue. So we call it what the pet spells. This thing should be on your finger. It's me. I learned this thing long time. I don't remember the last time I said I've met this scenario, so I should go and stress myself. No. You learn it over and over and over and over. You always make sure that you keep informations at your conscious mind. Okay, especially physiology. Marry your job. Okay, so that's it. Now
Hello, sir.
left to right. Yes, ma'am, Edna.
Yes, please. In such a case like this, if you get nursing a child who is crying, this recently I had a similar case like that. Actually, the child was the lower extremity and then hands and feet all were blue. You can see the physiology, everything. And the child, I was giving, when I take the SPO2, it was 64, 75. I gave the child oxygen. Still, I did a nursing intervention, new chest position. The child was crying. Actually, that the whole day I was disturbed because of the child. In such a child, like what will you do if the child is not coping? And the child is under, I think it's 1 year. The child is somewhere 1 year.
Yeah, those children. You know the problem with
Hmm.
managing this condition. The
Yeah,
majority of these children are infants. Okay.
yes.
The problem is
So
their
that,
ability to keep calm
yeah,
when you are managing them. You understand?
uh, yeah, okay.
Okay, so let me show you the trick. It's a very nice question that you've asked. Okay, sometimes when you ask me questions, it brings more ideas out. Okay, so this is the issue. The heart of the child has muscles. Okay, and the body of the child too has muscles or organs, all these stuffs. Okay, but remember, it is the heart that will collect blood and send some to the body. If the heart is not happy, if the heart is diseased, if the heart is failing, the body, it will never please the body. It will allow and see the body. Mm. Yes, it will satisfy itself first. This baby is crying. You have done all the niches, the oxygen administration, doing all those stuff. You have done it. Okay. But the difficult part with infants, with test spell, is this English crying. This condition, baby doesn't cry because when they cry, it means the heart muscles, it put pressure on the heart muscles. So the heart muscles will be demanding for oxygen. So you realize that the oxygen, that the little oxygen that will go to the lungs and come back to the, once they get out of the aorta, the coronary arteries will take a chunk of this oxygen and supply the heart. But still, and give only a little to the body. Can this little oxygen supply satisfy the whole body? No. The child is feeling discomfort at the exteriors, outside the heart. Okay. There's little oxygen that has been saturated. The heart muscle has collected it. So you realize that this baby is not clearing of what? Cyanosis. Because a chunk of the oxygen is going. Because if you don't give oxygen to the heart muscles will begin to die. And within some few minutes to hours, you see your troponin shooting up. You can get serious issues. The heart will collapse. So you see where your issue came from, Edna. So it was good you were a woman. You people know how to manage children who are crying. What can we do? This one, you don't need a pastor. Oh. Use your motherhood skills to calm this baby. Your duty is to let the baby stop crying so that you do nursing for the baby. Where is the mother? Is the patient, is the baby familiar with you? Is the mother? Meanwhile, at the same time, the nurses will sack the mother. Oh, madam, who understand you? See, the parents are distressed because their child is in serious distress. That spells. Okay. The parents will be praying, oh God, save my child. That is irritating the nurse. The nurse will tell the security, take this mother to the visiting room. The baby too is seeing a lot of health workers around him or her, and he's getting anxiety. What is going on? You know, children, infants, separation anxiety. So what can we do to let the baby stop crying? You give your oxygen. Baby is crying. The heart is accumulating, consuming the oxygen. So what do you do? Victor, do you have any skills for us? Yeah, so guys, nursing is beautiful. It's a beautiful job. It's very, very beautiful. Very beautiful. Right. So guys, let's do this one then. Maybe I'm not going to meet you tomorrow. And maybe tomorrow next, I will not be around. But there will be class. And I will join the class. I'm not going to do the presentation. Ayariga will do. So meet us tomorrow. Same time, same venue. Okay, let's look at the left to right. We know that for blood to cross to the lungs and come back to the left side of the heart, the left atrium, it is full of oxygen. Okay, so whether it passed through the atrium at the top, enter into the right atrium, goes to wherever it goes to, we don't care. Because once we get the whole blood to the lungs, we do cross. So these medical conditions, we call it what? Left side of the heart to right side of the heart defect, or a sign. No doctor will write this in any patient's folder. So you go and see the medical term, a cyanotic heart disease or defect. So once you see this English, you should know your answer to the question that follows, because you know the physiology now. Okay, good. So left to right. So defect occurs when oxygenated blood from the left side of the heart flows back to the right side into the lungs. Okay, where is it flowing from? This is my heart. This is the lung. Blood is gone. It's coming back. When it came here, we can have a hole in heart here. We can get a hole in heart here. We don't care. Our only issue is that a lot of blood went to the lungs and it's coming back. And remember, the left side of the heart, it has a lot of pressure than the right side. And the blood pressure or the heart pressure will push some of the blood from here to here. When the left atrium contracts, or when the atrium contracts, you will see what? Blood moving from here to here. And when the ventricles contract, you see blood moving from here to here. We don't care. If it comes here,
Hello, sir.
it will still go to the lungs, oxygenate, come back. If it gets here, it will still come here. It will go to the heart because the pressure here is more than the pressure here. And the pressure here is more than the pressure here. That's it. So this is it's a game of pressure. Okay. The one who has the highest pressure moves the blood. That's it. So we have this ventricular defect with high pressure. So when you do your apartment M, you hear, especially in this ventricles, you hear what we call systolic murmur. There is blood is moving with a high pressure going through chambers. Okay, and you are hearing the S3 and S4 sounds. It gives you signs of heart failure. We call it what? The holosystolic murmurs. Often closes spontaneously, if small. Then the atrium side. Okay, so you see that there is a fixed split of S2. So S2 is supposed to stand S2. We have S1, the systolic contraction. Okay, then we have the S2, the atrial contractions. Okay, when the atrium contracts like this, when you use your stethoscope, when you're doing blood pressure and you use your stethoscope, you hear loop, dop, loop, dop, loop, dop, loop, dop, loop, dop. Okay, the S2, the S2, which should give you only one sound like this, you hear two sounds, but that two sounds are always consistent, like somebody who has gotten atrial flutter. Okay, it's consistent. So loop, 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 loop. Meanwhile, the dot should be one. Okay, we call it fixed split S2. It is usually asymptomatic in infants. This child can grow with it. Like I was saying, a lot of people on this page, let's go to the lab, let's go to the CT scan, MRI, you get that disease. Nothing is happening. Everybody is walking about doing whatever we are doing until one day a blood clot will close your arteries. Then we will go and we'll take you to the cath lab. Then you say, oh, so you were having a hole in heart. Then we have the patent ductus arteriosus. Okay, so with patent ductus arteriosus, this is English word. Anytime you hear arteriosus, it means two arteries or plenty arteries. Okay, so there is one artery like this, and there is another one artery like this. Okay, so this is the and for some reason there is a hole that has been created between these two guys. So the blood that is supposed to flow from here, the aorta, remember apartment M, the aorta and the pulmonary arteries. So the aorta on top. So the aorta is full of oxygen, blood. It is going. When it got here, this hole that was supposed to close when the baby first cried, it refused to close. So blood will be moving from here to here. Okay. And they will still go to the lungs because of the pulmonary artery, go to the lungs, go and oxygenate, come back to the left ventricle. The left ventricle will give you to the aorta. The aorta will bring it, a little will drop here. We call it the patent ductus arteriosus. So you hear a certain mama, we call it machine-like mama. Don't worry, preterm babies, give them what? Endomethacin. You are done. Okay. Yes. Okay. So then we have the coaptation of the aorta, narrowing of the aorta. This is English. Okay. So you see upper extremity hypertension, lower extremity hypotension. That's it. When the aorta closes, there is a chunk of blood that will stay in the upper part, upper extremity here. So you check if you want to see that you have a problem with your aorta, aortic circulation. Check your blood pressure here. Okay. Then check for your legs. You will see a difference, a wide difference between it. Yes. When you check the systolic, you see a wide difference. Oh, okay. The aorta, because the hands are closer to the heart, the aorta doesn't struggle to flow blood. But because there is a close of this aorta or coarctation, narrowing of the aorta, the lower extremity, the legs, the aorta will not mind it. It will not send blood there. So blood circulation to the lower extremity goes down. What are the nature of the pulses? We have weak, thready pulses, and the muscles and the skin will show coolness, cold, clammy skin. That's it. We are done. We meet tomorrow for the rest. So, question time.
Yeah, yes, sir. Thank you for today's lectures. But the patent ductus arteriosus, please, sir, you were explaining, but I was a bit far from my device more. Please, you said it in a simple way. Please, I want you to repeat it for me, sir. Thank you.
Okay. So we have the ductus in cardiovascular system. We have the arteriosus and the venosus. Okay, the arteriosus and the venosus. So we have the patent ductus arteriosus and what the venosus. Okay, so you were here when we were doing the stethoscopy, apartment M. Okay, so you already know that when the two blood vessels leave the heart, we have the aorta and the pulmonary artery. Okay, when a baby is in the mother's womb, this is how it looks like. So this is the pulmonary artery, and this is the aorta. And remember, the blood pressure in the aorta is higher than the blood pressure in what? The pulmonary artery. Yes, they are all arteries, but the blood pressure in the aorta is always high. And I've told you that this is a game of pressure. The one who has the pressure will move the blood. Okay, so this hole was supposed to close when the baby first cried, but for some reason it did not close. But remember, this blood cannot flow because the pulmonary artery does not have enough pressure to push blood back to the aorta. So the aorta will always, when the heart contracts, the blood will move, boom. Some will drop here, and the rest will go to the system. That's why this child can live for 20 years. Nobody will know she has this problem. Because the blood inside the aorta is full of oxygen. So why stress? Okay. Yeah, full of oxygen. Once a while, they will have fatigue, listening, they are tired, and all. Yes, but it does not collapse them. Life goes on. When they rest, life goes on. Okay. Yeah. So, you see this problem with these kids, the patent. So, two arteries with a hole connecting it together. We call it what? Ductus arteriosus. There is a duct connecting two arteries. When you see a duct connecting two veins, we call it ductus venosus. Don't let them confuse you. And because this is a pressure game, when the pressure, if you like go and assess the pressure in this zone here, you see that yes, this is machine-like pressure. We call it mama. Same as the pressure that moves from here to here, the ventricular septal from left to right, we call it holosystolic mama. And you hear your S2 splitting. Like somebody who has heart failure. So when you go to the waterfalls and you see the pressure with which the water moves, you appreciate heart failure and holding heart. Okay. Yeah. Victor, are you okay? So there's a link on the page. If today is the first time you joined and you are not on any of our platforms, please. The link is on the chat box. Go there, click on it, YouTube, go and subscribe. We leave all the videos there, the short videos. Okay. Nowadays, I want to do more short videos for you so that you remember. Okay. Yes, because the brain is in such a way that if you don't bombard it with informations, it won't learn. It will be relaxed. Okay, we have the Facebook page. Go and like every information there, share. Okay, yes. Then the other TikTok and all those stuffs. Okay, we have the WhatsApp group. If you are not part, join. We share questions. Are you going to write your exam? Is it NCLEX? What exam? Nursing exam, health exam. We have our question. Yes, those who have registered for licensing exam who are going to write exam. We have a page. So that one is always questions, answers, rationales. Question. That is the language there. Questions, answers, rationale. Questions, answers, rationale. Questions, answers. You sleep and wake up. Questions are ongoing. You sleep, okay. Now their leader wants to do press sessions. Sometimes they use the Zoom link 3 times a day, 3 times a week. Monday, Wednesdays, nothing Fridays. Yeah. So if you join the question page, that is solely questions. This page you are seeing is solely physiology and content. Then we have the town hall meetings, which is about to start. The town hall meetings to short conditions. So we take one condition, one medical condition, then we discuss. Less than 1 hour, we leave. So the administrator in charge of that also be taking going. So myself and Ayariga, we run the content page. So please, that's it. Thank you so much, guys. God bless you. When you get this information, share it for people to join. Okay. This is a philanthropic project we are doing. So invite people to come in. enjoy as you are enjoying. God bless.
Thank you so much, Sakurai. God bless you. Very good.
Okay, God bless you too. Somebody is asking the location of the town hall meeting. Yeah, the town hall meeting will be, we are yet to bring the location. Okay, we are yet to bring the location. So all announcements will be posted to the platform, our WhatsApp platform. Okay, so you join the town hall meetings. Okay, yeah, thank you so much. And please, if you are here for examination and you pass, don't leave the page after you pass. You're doing a disservice to yourself. Because the moment you stop learning, all this sharpness, knowledge you gain, it will diffuse. It will just go down, sink down. So you begin to rust. Health worker should not rust in his profession or her profession. Take note of that. Okay. Thank you. God bless. Let me stop the share. And those of you who are watching from online, Facebook and YouTube, the videos are there. Ask all your questions. We will answer you as we always do. Okay. And if you are also joining from the Zoom link, when you go to the Facebook or the YouTube page, the videos are there. It is there forever. Just go and watch, download, share, let others also enjoy. Okay. Thank you so much. This is a free page. Don't pay money. It's a free page. And the choice is yours. I can't say don't pay money. If you want to pay money, that's fine. But we are not taking money here. Okay. That's it. Thank you, guys.